Okay, good afternoon, everyone. Let's go ahead and get started. Nice to see many of you in person today. Thank you for being here, as well as to many of you who are online. My name is Vineet Chopra. I'm the chair of the Department of Medicine. I will announce our speakers shortly. I want to provide first a few quick updates. You'll see on the slides above me our carousel that's sort of spinning of future and coming attractions in the Department of Medicine. I want to highlight just a few. First and foremost, Mentorship Academy. For those of you who came last year, please also consider coming this year. We have new content and we have new areas that we're developing, including specific guidance for advanced practice providers, for staff, and for trainees. For those of you who don't know what I'm talking about, the Mentorship Academy is a one-day workshop that focuses on teaching you the best ways to become an excellent mentor and a solid mentee. We cover things like conflict management. We cover things like goal setting, finding your purpose, but also thinking about mentoring across differences, both generations and backgrounds, as well as some of the thorny issues that come up along the way. It is a day of energy and of excitement, and I highly recommend you attend if you haven't before. So mark your calendars, November 4th, 8 a.m. to 6 p.m. at the Hyatt Regency. Second announcement, we have a number of incredible grand rounds coming up, so I want you to mark your calendars for that. Next week, we have our Systems Improvement Conference. That is a hybrid event, so please join online where we will work through a case and think about systems and how they contributed to some of those challenges and how we can do better in terms of the environment we work in. On the 18th, Dr. Curtis will be here. She's coming from the State University of New York in Buffalo. She's the chair of medicine there. She's also one of the first female electrophysicians in this country, and will tell you a little bit about her journey in EP, but also about new adventures in atrial fibrillation. It will be, I think, a very enthralling discussion. On the 25th, Dr. John Carruthers, who's the Vice Chancellor of the University of California, San Diego, will be here. He'll be talking to us about hereditary colon cancers and the epigenetics thereof. He's also a fantastic speaker, so please mark your calendars. We have a number of incredible external speakers coming. Today's Grand Rounds is being given by a member of the Division of Hematology. And as some of you may have seen, we have some leadership transitions there that I would like to announce formally today. I have mixed emotions about this because Dr. Craig Jordan has been somebody I've worked with very closely for the past 3 years, but he and I have decided that he will transition out of his role as the Division Chief of Hematology effective October 15th. This is not because he's in trouble. This is because Dr. Jordan has many more adventures ahead of him in terms of innovations and areas that he wants to focus on in research. And so he is moving on to many great pastures here in the Department of Medicine. I am thrilled to announce that Dr. Dan Pollier, who's here with us today, who is currently the Associate Division Head for Clinical Affairs, will serve as Interim Division Head once Dr. Jordan steps down. We will begin a national search for a new Chief of Hematology in the near future, but I am both grateful to Dr. Jordan and Dr. Pollier for their leadership and for their continued support during this transition. So Dan, welcome, and good luck on the many adventures that lie ahead. All right, with that, I am pleased to welcome our speaker today, Dr. Jonathan Gutman, who is a professor of medicine in the Division of Hematology here at Colorado. John completed his undergraduate studies at Princeton, followed by medical school at New York University, and both his internship and residency at the University of Colorado. After residency, Dr. Gutman completed fellowships at the University of Washington, as well as the Fred Hutch Research Cancer Center. I will tell you that he is not only a well-respected but highly regarded clinician and a well-funded investigator in blood cancers and in cell transplantation, especially in cord blood transplantation. He served as the co-medical director for the CU Cord Blood Bank since 2009, the CU Lab Medical Director for Clinical Stem Cells since 2011, and the CU Cancer Center's Scientific Review Executive Committee since 2016, among a member of additional administrative roles. He has won numerous awards, and I will give you just a few. First and foremost, he won the University of Colorado Cancer Center Award for Outstanding Leadership of PRMS. And last year, he was inducted into the Department of Medicine's Clinical Excellence Society as one of our doctors, the best of the best that we have here at the University of Colorado. So I'm delighted to welcome him today to give us his grand rounds. Please welcome Dr. Gutman to discuss the future of cellular therapy in 2024. John.
Oh, perfect. Thank you. All right. Well, thank you very much, Vineet. Thanks for the opportunity to talk about this topic, which I think is a pretty exciting one for the field of medicine at large. Certainly very exciting for us in the world of hematology, where much of it got its start. I hope to talk today for about 50 minutes or so, and then have a little bit of time for some questions at the end. I will say I'm ordinarily a pretty loud talker, but a little hoarse today, so hopefully this is projecting okay and everyone can hear me, but raise your hand in the back if you can't at all. I will also add that my parents are availing themselves of the services of our fine hospital today, so they're sitting back there somewhere, and I'll have to be on best behavior for that. But let's dive in here. So I titled this talk, Cellular Therapy in 2024, What, Why, When, and Who, and Where Are We Going? My dear colleague Manali Kamdar, who I've foisted off to cover the Kaiser Tumor Board today, which is a service we provide. She was pestering me about the title, what's the title, why the title? And I added here in the bottom this little note, a second act in an American life. I was reading a little bit about this F. Scott Fitzgerald quote, and I think he did in fact believe in the possibility of second acts in American lives. But for those of you with extraordinary elephant memories, you'll certainly recall, and I think relevant to this question of a second act, November 4th, 2009, the last time that I gave grand rounds in the Department of Medicine. And at the time, I was talking about adult cord blood transplant. What, when, who, and where are we going? The picture has not changed, but I'm told that it should. Got to take care of that. But this was very shortly after I came back to the University of Colorado. We were building out our stem cell transplant program. I was very gung-ho on all the work I'd done in cord blood transplantation up in Seattle and the program that we were going to build. When I give an introductory talk to CAR T cell therapy to the residents and fellows, I often try and start it out with sort of a lesson, a history from two perspectives, one of them being mine and one of them being more broad. I don't know that I need to waste a lot of medicine grand rounds time on my personal perspective, but I will say that I had the opportunity when I was in fellowship to be working on a lab where I was working on cord blood transplant in the lab of a guy named Stan Riddell, who is a major leader in the world of cell therapy. And sitting across from me was another fellow who was going down and putting CD4 to CD8 ratio T cells into the monkeys, developing what would become the CAR T cell product Breyanzi. And so I like to then go on and show cord blood transplant for a variety of forces, another conversation we could have, is on an absolute decline. And macro forces are making that just not something that's possible. And then on the other slide, I will show the IPO of Juno, the company producing Breyanzi. And I think I made the wrong choice, but remember for the fellows and residents, what you do now, you could be a part of something very big. And so the other lens through which I like to start this conversation is talking a little bit about Emily Whitehead. And I don't know if any of you know who she is, but in April of 2012, she was at Children's Hospital of Pennsylvania, and she had horrible refractory acute lymphoblastic leukemia. ALL is a disease that we've made a lot of strides in with conventional chemotherapy. We cure it in the vast majority of kids these days, but for those kids in whom we don't cure it up front, it can be really a challenging disease. And 2012, Emily had refractory leukemia, teeming through her, days to live, guaranteed, no options. And She became the first patient ever or the first child ever to be infused with this new therapy, this CAR T cell therapy. And there's a sort of another layer to this story, which I don't think I'm making up. I've had it confirmed before, and if there's any embellishment in it at all, I like it enough that it's worth it. Carl June, who was one of the other pioneers of CAR T cell and was responsible for the trial that Emily went on to. He had a kid who had juvenile rheumatoid arthritis. And the night that they infused these cells into Emily for the first time, she got sicker than sick. Temperature well over 40 degrees, blood pressure dropping, fluid filling the lungs, thought she was going to die. They ran a panel of cytokines and her IL-6 levels were absolutely through the roof. And Carl June's kid was taking this new drug, tocilizumab, to see how it might work for his juvenile rheumatoid arthritis. And as the story goes, they said, well, let's give this to her and see what happens. And this kid, death's door, guaranteed death, unbelievably sick, calmed down that night, everything got better. And here she is. It's just such a great story. I can't get that Obama picture if someone can find a higher resolution version, I'd love it. But this is her 10-year anniversary, cured of the disease, doing great. If that's not what we strive for, then I don't know. It reminds me, there's another famous T-cell biologist, Bill Greenberg at the Hutch, and he used to say, I want to make therapies that don't require statisticians to tell me whether they work or not. And so, this stuff, I think, super exciting. So what I want to do today is I want to talk a little bit about the current state of cell therapy, the modalities that we're dealing with. CAR T cell therapy is the one that's discussed most, but also there's some new kids on the block, tumor infiltrating lymphocytes, T cell receptors. There's lots of different kinds of therapies. I want to touch base about them a bit. Not going to talk much about gene therapy today, although that's a bit of an offshoot, I would say, and overlap with cell therapies. I think of gene therapy more, though, as the insertion of a gene into often a stem cell that's going to be constitutively active to help produce some needed gene. So we now have approvals for those in hemophilia and in sickle cell anemia, but that's a bit of another topic. I think stem cell transplant, bone marrow transplant, autologous allogeneic transplant can be considered a form of cell therapy, but we're not going to dwell on that today. That's kind of old school stuff. And then I want to talk about the state of these different modalities vis-a-vis the different places where we're using them, because that's an exciting set of issues also. And then finally, I want to take a minute to review our institutional scientific contributions to the field and think a bit about some of the operational considerations we're facing as these cell therapies grow very rapidly, because they are growing very rapidly. Before we dive in further, a couple of key just considerations to bear in mind. This is a field that is evolving very, very rapidly. And there are new and iterative modalities under constant investigation. And so what we're dealing with today is probably not very similar to what we're going to be dealing with in 5 years in this space. And I think an important point that sometimes gets lost, because we talk a lot about CAR T cells these days, is that these different therapies are going to have different clinical and operational characteristics, and we're going to have to be thinking about those as we move things forward. Concurrently, as always, other therapies are being developed that may replace or do as well but more easily than these types of therapies. Specifically, there are things called bispecific, trispecific T-cell engagers, which are, I think of as kind of poor man's cell therapies, little ball with a few receptors that bring immune cells together with bad cells, but easier to deal with. The number of diseases and the associated stakeholders is expanding rapidly in this field. Whatever system we choose to develop at our institution to deal with this, we're going to need to be adaptable and flexible. There are now a number of standard of care FDA-approved agents in the space and lots more in clinical trials. The two raise some different operational issues, so we'll just touch base on that question. So I am not a particular fan for any reason of the new kids on the block. And I don't exactly know what inspired me to throw this in here, but this is the old new kids on the block, the aged, now current new kids on the block. And I think of them as being somewhat similar to the CAR T cells in the cell therapy space. Remember them, they may reappear later. So let's start with the conversation about CAR Ts. CAR T cells chimeric antigen receptor T cells. Probably many of you have heard of. Some of you maybe on the wards in the ICU have dealt with patients receiving them. But what a CAR T cell is it is a T cell that we have transfected with a viral vector to insert that viral vector, the payload of that viral vector into the T cells to have them start producing this chimeric antigen receptor. And what the chimeric antigen receptor is a target that we, let's see if this little bugger's working. Yeah. Well, the bottom of the slide there, it's a target molecule, a receptor that we want these T cells to target, and then the rest of the T cell activating apparatus attached behind it, a co-stimulatory molecule and a T cell and a signaling molecule that will activate T cells. And we insert these receptors into these cells, we grow these cells up, and then we put them back into a patient and we harness those T cells to target what we want them to target. So pretty cool kind of space age stuff. I think it is important to understand CAR T cell therapy is very complicated therapy. The path that patients go through, the patient journey, is quite complex. Patient will meet with the team about the possibility of moving forward with CAR T cell therapy. They'll need to be evaluated by psychosocial, by exams, by organ system evaluation, insurance approval. And then what we do in the circumstances of most CAR Ts these days is what we call leukapheresis. We collect up the patient's cells and we collect those T cells, and then they are sent to the manufacturer, whether it be here or a company, and the manufacturer will produce the CAR T cells and grow the CAR T cells. These patients may be very sick. They may need chemotherapy during the interval, the 2 to 3 weeks that it takes to grow these CAR T cells to control the disease for which we plan to give the CAR Ts. But then at the end of, but then we will bring the patients in. We give them lymphodepleting chemotherapy, usually fludarabine and cyclophosphamide, for about 3 days prior to the infusion of the cells. And what this does is it knocks down their lymphocytes in a way that creates a cytokine environment that is stimulatory to the growth of the lymphocytes. And then we infuse the cells in, we put them in, we watch the patient, and we hope that they go and destroy all the cancer and cure the patient of what was an otherwise incurable disease. So that's the story. And you know, these drugs, they're really a living drug. This is a person's own T cells that we have manipulated slightly, put back into them. And so the response that we see is very similar to the physiologic immune response that you might see in a patient who has an infection. We infuse the CAR T cells after the lymphodepletion. The lymphodepletion stimulates the environment to get them growing, as do any cancer cells that are lurking around expressing the marker on their surface that we are trying to attack. The CAR T cells will rapidly expand. They'll grow up real quickly, and then they'll dip back down after a few weeks, and we can see the levels in the blood. But this big expansion is where we think a lot of the action is in these cells, hopefully killing off the underlying disease. So we, I also will tell the fellows in residency, if you want to get a paper in the New England Journal or Lancet, just do a CAR T cell trial, because every week there's one in there to look at. But what I've just highlighted here, the most work in this space has been in the blood cancer space. It's where we are most developed by far. And the diseases for which we have had the most success include acute lymphoblastic leukemia, and then a variety of B-cell lymphomas, particularly diffuse large B-cell lymphoma, mantle cell lymphoma, follicular lymphoma, and then more recently also multiple myeloma. Again, the details of all of these diseases probably a little beyond the scope of what we want to talk about. But what I think is striking, this is just a summary of some of the registration trials for these various CAR T products, is that if you look at these overall response rates, they sit between 80 and 100%. These are patients who typically had no good alternatives. And so this is really fairly remarkable. And the complete response rates in these patients, the absolute removal of detectable disease, sitting in the 40 to 60% range with these CAR T therapies. And though, they are not always curative and we are learning and learning, I think it is fair to say that it is probably true that roughly 30 to 40% of aggressive lymphoma or ALL patients are likely being cured by these therapies who otherwise were certain to die. So, there's that's not too bad. As I noted, we have a number of them that have now been FDA approved. These CAR T therapies, these living drugs, they don't really fit the traditional paradigm. And so we've had to work through with the FDA how this all looks. But I've listed the characteristics of the 6 CAR T cell therapies that have been approved to date and the indications in which they are indicated. One of the most important things about a CAR T cell is what is the target? What are you trying to hit? And the place where we've been most successful is the receptor that's on B cells, CD19. And the majority of CAR T cells that are in clinical use right now target CD19. It's present on B cells, it's present on B cell malignancies. For multiple myeloma, we have 2 new CAR T cells that target BCMA, which is a surface marker on the plasma cells. And the CAR Ts, they're relatively similar, but they have some difference in their details. The co-stimulatory molecule that's used, 41BB or CD28, that's a naturally occurring molecule that helps to stimulate T cells. Depending on which one you choose, you might have some different characteristics to your CAR T cell. But a lot of this stuff is under investigation. I highlighted in red, though, some of the more recent approvals. And an important point that I want to make about them, which I will come back to, is that as is the case with most drug development, we start out where giving these drugs to patients who are in horrible relapsed refractory settings, or, testing safety, not necessarily expecting a lot of efficacy, which, by the way, makes a 90% efficacy rate look pretty good. But when those drugs prove themselves, we start moving them earlier and earlier into lines of therapy. And what we're seeing now is these CAR T cells being moved into earlier and earlier lines of therapy, such that after 2 lines of therapy now, we are able to use Breyanzi and Carvykti, multiple myeloma therapy, was just approved after 1 line of therapy. So that raises a set of other issues that we'll talk about a bit. But this stuff, it's happening, it's moving forward, quite exciting. So when these CAR T cells fail, why do they fail? There are generally thought to be 2 main reasons in the context of blood cancers that CAR T cell therapies might fail. And this survival plot from the New England Journal, I think, demonstrates to some degree a sense of where these 2 failures occur and why they might occur. You see sort of 2 steps down in the survival curve. The first we generally think of as occurring when we might have early loss of the CAR Ts. We put the CAR T cells in, they kind of just fizzle out and we can't detect them. So if they just kind of go away, they may not offer that protective effect, and that is a setup for concern for relapse. Second issue, though, is that at least in the setting of cancers, the cancers can become resistant to the CAR T. They can stop expressing CD19, can start expressing other things. And so leukemic resistance is another common reason why CAR T cells might fail a patient and the disease might relapse. These things are not entirely benign. Sort of talked about the story of Emily at the beginning here. There are a number of toxicities associated with these CAR T cell therapies. And again, they can sometimes get conflated a little with some of the newer therapies. And I think we have to be careful about that, because every one of these things that we try in a new patient is going to potentially have its own new set of toxicities. We don't get trapped into just thinking that this is what's going to happen with everybody. But we give patients chemo, we give them lymphodepleting chemo, that has its issues. There is always the concern of any of these things attacking off target, attacking receptors on the surface of cells that we don't want them to attack. So finding a good target is really critical. CD19 is a nice target, attacks B cells, but patients end up B cell aplastic and do need IVIG because they don't produce antibodies after these CAR T cells. But then the big two of toxicities that we think about and talk about with CAR T, we call cytokine release syndrome and neurotoxicity. And this is specifically true of CD19 CARs. Looks like it's probably true in BCMA CARs also, but we have to see as we develop new CARs. And I'll talk about those in a little bit more detail. With the BCMA CARs, which we use for multiple myeloma, there have been some reports of patients developing Parkinsonian type symptoms after in the months after infusion. So that's something we're going to have to watch for very closely. There may be something going on with dopamine producing cells. Always a question when there's genetic manipulation of the possibility of insertional mutagenesis inducing a cancer. I'll talk about that in a minute. With some of the newer CARs targeting some newer receptors, particularly CD22, there's been this massive immune activation HLH-like syndrome that has now gotten a name, CAR-associated macrophage activation syndrome, HLH, that can develop a month or two after and can be quite profound. And then infections, the replication of the virus, uncontrolled T-cell proliferation, all possible issues. The cytokine release syndrome is what Emily experienced for sure. It's really just an overly exuberant immune response occurring as these cells go into the patient and flare up. We have a grading system to grade how severe it is, marked by fever, hypotension, hypoxia. Patients can get real sick with this. They can end up in the ICU. They can end up intubated on pressors. But we're getting better and better at avoiding those very severe toxic pictures. The overall incidence depends a little on the co-stimulatory molecule, the disease, the burden of disease, et cetera, but probably runs somewhere from 35 to 95% with some products. Most of it's very controllable, easily managed with some tocilizumab, maybe some steroids, number of investigational anti-inflammatory drugs that are being considered in cytokine release syndrome. But by taking patients whose disease is a bit more under control, that seems to help ameliorate things. Usually happens in the period roughly 3 to 7 days after the infusion of cells. And we generally get patients through it, but it can be a significant thing. The other thing, and this may be a bit more unique to CD19 CARs, sort of, let's see, but patients can get this unusual neurotoxicity phenomenon, which typically will develop somewhere between 10 days and 3 weeks after the infusion of the cells. And it can really do anything. People can have seizures, they can have intracranial swelling, they can have motor deficits, they can become completely confused. We've had some people do some pretty crazy things up there experiencing neurotoxicity. And incidence there, again, probably somewhere between 20 and 60%, depending on details. Grade 3 to 4, which can be quite significant, and people can become obtunded, and it's scary. 4 to even 31% in highest cases. We'll rule out other issues. We'll try and be supportive about it. I don't think anyone really knows what to do about it. We give steroids to help calm inflammation, but generally people get better. But it is a significant additional concern with CAR T cells. And then I want to take a minute to highlight something that may have come to some of your guys' attention. I don't know, but sort of out of nowhere, on November 28th, 2023, the FDA announced that it was investigating the serious risk of T-cell malignancy following CAR T-cell therapy with the approved BCMA or CD19-directed agents. So again, anytime you're mucking around with the genes, we worry about insertional mutagenesis. We worry about the possibility of triggering a malignancy. And so this was a little alarming to folks. But as it has turned out, thus far, doesn't really seem like this is a significant issue. There was a case in the New England Journal reported just a couple of months ago where they described pretty clearly a CD4 lymphoma developing following CAR T-cell therapy. The patient did have some known abnormalities in their stem cells, which are often associated with the development of malignancies. So a little unclear what the issue was there. But definitely the CAR T cells did become malignant. Stanford just produced a large series on their risk of second tumors and T-cell lymphoma after CAR T-cell therapy, found it incredibly low. Some of the leaders in the field in 2020, in the last couple of months, published a letter in Nature Medicine in which they gave a little more information because the FDA just sort of made this announcement without information. They said that basically there were 20 reports in their reporting system of possible T-cell malignancies. Among 8,000 patients in the system, 34,000 patients that had been treated. But of these 20 cases, there was a lot of detail missing, hard to say. So I think the jury is a bit out on whether this is an issue or not. And I think right now it is strongly felt that the benefits outweigh the risks. And I will point out that for many of these patients, the alternative standard of care may be something called an autologous stem cell transplant. We give high-dose chemotherapy and we put the cells back into the patient. It is known that 5 to 10% of patients undergoing autologous stem cell transplant will develop secondary myelodysplastic syndrome a year or two later, and that is often a lethal disease. So, we must bear in mind trade-offs as we're thinking about these issues. In the bottom right there, I do have a letter that was published in Blood that is, I think, another warning sign. Now, this was a different type. This was a CAR T cell where they attempted to use something very different than a viral vector to insert the genome to produce the CAR T. This stuff gets out of my league pretty quickly, but this piggyback system, there were 2 cases of clear associated malignancy with this system. So it is something we have to be careful about, but the viral vectors we've been using for most of these, I think, felt to be pretty safe. And as I mentioned earlier, what happens with these therapies when they're successful? Well, we start moving them earlier and earlier into treatment. And I've just highlighted here a couple of studies representative of that. The top 2 studies are the 2 studies that have led to CAR T cell becoming standard second-line therapy in diffuse large B-cell lymphoma. They compared historical standard autologous transplant to the use of CAR T, and you can see a pretty clear separation in those survival curves, or progression-free survival curves, that have translated into overall survival improvements. And like to highlight again, Dr. Kamdar, who was the lead author on the Lancet study, the Transform trial that established Breyanzi. Our center put the most patients on, so that's great. In the bottom right, we have Carvykti, the multiple myeloma CAR T that has now been approved after first-line failure therapy. Again, progression-free survival very significantly improved compared to standard of care. But again, these are 2-year follow-ups, 2.5-year follow-ups. So, we're not done here. On the bottom left, a study looking at very high-risk diffuse large B-cell lymphoma defined by molecular abnormalities response to therapy, and first-line use of CAR T therapies. I will note too, I'll come back and highlight a little our own institutional accomplishments in this space. My colleague Mark Schwartz has a trial in ALL with a CD19 CAR that we've produced on campus, where we are trying to give it upfront in patients who have low-level detectable disease after their initial therapy. So an exciting, potentially paradigm-changing trial that we're pioneering here at our institution. So as we think about CAR T cell therapy and what do we need to do to improve upon it, the principles here are applicable to CAR T. I think they're generally applicable to cell therapies across the board, and they're definitely applicable to both solid tumor and heme malignancy cell therapies. One issue is trying to prevent relapse. And so people are making multiple targets, CD19 and CD22, CD19 and CD20, to try and prevent the cells from the malignant cells from being able to get around resistance easily. Improving potency of the CAR Ts. Trying to get these T cells to not be exhausted and to be able to get into the tumor microenvironment that is inherently immunosuppressive, particularly in solid organ transplants, is something that people are working on hard. Strategies to get the cells to persist more. These armored CARs, they're putting in constitutively activated cytokines that also are present with the receptor to help try and get the cells to persist and get them through the microenvironment. Some people are putting suicide switches into the CAR T so you can shut them off if things rage out of control. Some people are trying to traffic them better to targets using tracking receptors. And then I think everybody would love to make this whole thing a lot simpler. And so people are working on off-the-shelf CAR products where they knock out HLA or do this and that to try and make it so that we can just have a shelf product that can be used universally. People are looking at other strategies to try and develop and manufacture these cells more quickly. People are working on in vivo strategies where you just take a few cells, you put them into the patient and get them to grow within the patient. So there's a lot of super cool scientific work to be done here and going on here. And the numbers are significant. So if we look at the pipeline, these are cancer trials, immune effector cells, cell therapies in the cancer pipeline. This slide shows for different types of these cell therapies, CAR T cells being at top there, the most common, but other cell therapies, TCR, T cell receptor therapies, we'll touch base on, tumor infiltrating lymphocytes, NK cell therapies, CAR NK cell therapies, all these different types of immune cells being harnessed. Lots of trials going on. On the right, there are just a number of targets that are being investigated in different settings. And the color scheme there on the left indicates different diseases for which these trials are being undertaken. The most are occurring in the heme malignancy space, but solid cancers, all different types of solid cancers being targeted with different receptors, all very, very active stuff. And it's a large pipeline. Oh, they're back. These are the young new kids on the block back in the day. And so this is our 2024 approvals. We've got a few, we've got some new stuff here. So in 2024, the first cell therapies outside of the heme malignancy space have been approved, and they're actually not CAR T cells. One is a tumor infiltrating lymphocyte product for melanoma, and one is a T cell receptor therapy product in sarcoma. So we've started to enter the world of solid tumor oncology. The melanoma project, lifileucel, these things all have like 3 different names that are completely impossible. So I kind of roll with one of them and I can't ever remember any of it. But lifileucel is a tumor infiltrating lymphocyte product. So it's been known for a long time, melanoma is a very immunogenic tumor. The immune system responds to it. And so what they do is they go into the OR, they harvest some of the tumor, they send it off to the manufacturer who isolates the lymphocytes infiltrating the tumor. They expand them, and then they send it back to us, and we give lymphodepleting chemotherapy. We put the lymphocytes into the patient. We infuse high-dose IL-2, which gets the patients very sick and stimulates the immune system, and hopefully they are cured of their melanoma. The waterfall plot and survivor plot of the trial that led to the approval of lifileucel is indicated there. As with many of these therapies, response rates among those who respond well, they can be very, very durable, but not everybody does respond. But these are very, very heavily pretreated patients. The other product, Tecelra, is a TCR, a T cell receptor. So this is a type of cell therapy where we take an actual native T cell receptor. We might manipulate it a little bit so that it will more effectively target whatever peptide we're having it try and target. And we put it into the T cells. And so we are truly using the T cell receptor as it is designed to stimulate the T cells as they are physiologically designed. And so when you do these things, you need to have HLA matching between the T cell receptor and the HLA of the patient. So they're usually done in A2 patients. HLA-A2 patients are the most common. It's the most common variant of HLA-A. We can have a discussion of HLA some other time. But you got to find the right type of patient. And then the tumors have to express the antigen you're targeting, which in this case is MAGE-A4. So for these synovial sarcomas, which are already very, very rare, about 30% of patients will meet those criteria. And if they do, then those patients are leukapheresed, sent to manufacturer who inserts this MAGE-A4 receptor, lymphodepleting chemotherapy, infusion, and monitoring. And again, this is a bad cancer. I don't know it very well, but impressive responses, and among some, complete remissions, durable and sustainable. So then I want to touch base about autoimmunity, because this is a big place where this is going to. Again, New England Journal paper, several papers, Nature Medicine, blah, blah. In the autoimmune space, there's been a lot of enthusiasm about the potential for CD19 CAR T cells. And this is a recent paper in the New England Journal of Medicine reporting on 15 patients with several autoimmune diseases, most lupus. And it's just a case series of remarkable responses with CD19 CARs in incredibly refractory patients. And so there are a lot of different diseases that people are thinking about: myasthenia, rheumatoid arthritis, ankylosing vasculitis, list goes on there. At the bottom, stiff person syndrome. We'll come back to that one in a minute. But autoimmune space is being strongly infiltrated. Now, this slide here shows the volume of studies as they are rapidly increasing. On the left, we have sort of a schematic of various companies and the products that they're developing. Those who know me well know that the talk that I would rather be giving right now is about climate change mitigation and the energy transition off of fossil fuels. That's something I really, really love learning about and have spent a lot of energy on. I've also made an unsuccessful effort to become extraordinarily rich by trading options around the energy transition. I went in November of 2021 and everything is down 80% since, but that's systemic, not my issue. But your task here is to pick out which of these EV companies has gone bankrupt, because I do think we're in a bit of a dot-com bubble around rheumatologic CAR T cells, autoimmune CAR T cells. There are a lot of companies exploring this space. I'm not sure there are going to be enough patients, no matter how good these things are, given alternative therapeutics, to think about CAR T for these patients. But it's an exciting time for sure. When we think about autoimmune disease as compared to malignant disease, a few things that I think we need to bear in mind. The risk-benefit profile is very different for an autoimmune patient than it is for a patient with a horrible leukemia who's going to die in the next weeks if we do nothing. We have to be careful about that. The population is less acutely ill, buys us a little time, makes it easier for us to be able to sort of work under the parameters that we often need for these patients. You know, people ask, well, why might these things be successful? It is generally felt, I think, that these CAR T cells, again, because they are living cells, they are harnessing our physiologic immune systems, are capable of getting into tissues and deeply depleting B cells in ways that our antibody rituximab can't do, or even these bispecific T cell engagers we're trying to develop. Some questions about CAR Ts and autoimmunity as compared to cancer. Do they need to persist, or can we just do a B cell reboot? Can we do things to minimize CRS and neurotoxicity in this patient population? What's the best co-stimulatory molecule? Do we need lymphodepletion? These are all things under investigation. So the other thing is that I'm in the, some know, I'm in the process, for not entirely clear reasons, of just finishing up getting an MBA in health administration. So I'm very interested also in thinking about operational issues. If you're interested in social issues around medicine, don't go to an MBA. I learned that very quickly. They don't want to talk about that. But cost and cost effectiveness are important issues. And I think they're very important to bear in mind as we think about these therapies, because these things are expensive. Their jacking prices, Yescarta, the first approved in 2017, $373,000 for a dose. That's the cost. That's not like what we charge for it. And they increased that to $424,000 last year. A little thing that I like to point out about the system, Kymriah is one of the CAR T cells. It is exactly the same drug. When administered to an adult for DLBCL, $373,000. When administered to a child for ALL, $475,000. And that's just a function of quality of life years gained that they use to do pricing. You'll also notice these are sort of in order of development. And as we track down the ones approved more recently, the prices are going higher and higher. This Tecelra thing for the T cell receptor, $727,000 for a dose. So, you know, these are a lot of money. And it's been estimated that at scale, the manufacturing costs of one of these is $18,000 to $20,000. So that's a pretty big markup. But you know, pharmacy pricing and all that is super complicated and beyond anything I think anyone can wrap their head around. But it is a big issue. And I think in order to understand whether these things are cost effective, these kinds of analyses that can be done are all over the map. I've given an intrepid person who might be interested a long list of studies that they can go and look at to suss this out, but you will find all over the map. And then it comes down to a lot of modeling considerations. What are the cure rates with these things? How long are the remissions? What does the natural disease course look like? What are the alternative therapeutic options and associated costs? What does the quality of life look like for the patients? And you'll generally aggregate that to compare it to something called a willingness to pay rate, which is, you know, what society deems reasonable for a quality adjusted life year, usually around $50,000 to $100,000. But important set of issues that we don't want to forget. All right, I want to finish up talking a little bit about our institutional efforts, what we have going on here, and delve a little bit into some of the operational considerations that we have to think about as we think about how we're going to be approaching CAR T cells and cell therapies at large across our institution. So there's sort of three buckets I like to think about. We have an institutional academic arm, the Gates Institute, led by Terry Fry, that was recently infused with $200 million from the Gates family and support to help get going our institutional cellular therapy and regenerative medicine internal arms. And we are developing internal products in the Gates Institute, and then the goal is to conduct phase 1 studies, clinical studies. We have a biomanufacturing facility. We can produce our own CARs, and we have several trials now actively accruing using a CD19 that we developed and went through the exercise of getting all regulatory approval through on campus. Also a CD19 by 22 CAR, which is a newer bicistronic CAR targeting 2 targets. And that's exciting and great. And there's a pipeline of products, and people interested in learning more about the Gates Institute would strongly encourage you to, because there's a lot going on. As far as industry-sponsored research, we have completed a number of trials. We are accruing to a number of trials, and we are opening multiple trials. Most in hematology, many in solid tumor oncology, and many now also opening in the autoimmune space. As I mentioned, Dr. Kamdar was the lead author on the TRANSFORM study that got DLBCL approved second line. Teresa Medina was the lead among the melanoma docs, lead accruer for the tumor-infiltrating lymphocyte product that's now approved. Bree Wilkie was enrolled in the Tecelra trial for that trial that's now been approved. Amber Podol from nephrology put the first U.S. patient on a lupus nephritis trial about almost a year ago, probably now. Larry Moreland has put the first patient onto a rheumatoid arthritis regulatory CAR T in the last couple of months in the US. So, you know, we're staking a claim here. It's exciting. And then you got your standard of care CARs. And they all, so we have currently onboarded all standard of care cell therapy products. We're in the process of getting the melanoma TIL and sarcoma TCR onboarded. We have all of the CAR Ts that have been around for a while. We've developed an institutional approach, a committee to help consider the product, consider future products. We're building in a lot of structure around all of this. I don't think we're necessarily going to be able to open every single one of these things that gets approved, but we're thinking about it for sure. As we think about how we might organize ourselves around this on a broader level, because this stuff, again, it is a multimodality, it is multidisciplinary, it involves the collaboration of many, and we want to create a system that enables that, includes everybody, but is also effective and able to do this efficiently. So one of the things that's been very important in this has been UC Health hospital recognition that cell therapies are important, they're big, and we need to pay some attention to them, and that we want to be worldwide leaders in the space. And they've created 2 director-level positions, a director of cellular therapy for nursing and a director of cellular therapy for operations. Aaron Stoner and Aaron Weston occupy those positions. They are great. They are incredible assets. We are working and making incredible progress at trying to develop a system that's going to work for everybody. And then I think what we envision as a third tier in this is a overarching cellular therapy medical director to help oversee all of the work that's going on in this space and rein in all of the chaos that is associated with it. And then in each of the different areas in which cellular therapies are potentially being developed and being used, a sort of an associate level director who is helping in that particular area with the particular issues. And this is a model that we're sort of working toward making good progress around. I think also we've talked to lots of centers about how they're setting things up, but this important question is raised. There is a lot about these therapies that is common and is also different than what goes on in many other areas of medicine. And what I think we envision as the path that we are on, and we're pretty well on the road toward getting there at this point, is that we will have some sort of central resource that is a cellular therapy clinic so that patients agnostic of disease, when they go into the phase of treatment for their cell therapy, whatever the details of that phase of treatment look like, they're going to go to a central resource where we take care of them, we synergize, we use economies of scale and expertise to take care of the patients through the episode of the care, with the complete input of whoever the primary team is also taking care of the patient. And many folks in rheumatology, medical oncology may become cell therapists in the not too distant future. It's up to them to some degree, but there's criteria we have to consider and things we have to do to make sure we do that. But they come for that episode of care, then they go back to their home clinic. This is important, particularly when things become standard of care. They become very regulated. And we want to make sure that we're doing this in a as efficient a way as we possibly can, and in accordance with regulatory requirements, both again for efficiency, for best patient care, for insurance contracting, for everything. Well, a last slide on another piece of the puzzle that we have to think about, I think very important, is clinical trial support. I think this swings a little more over to the side of the School of Medicine than it does the hospital, but I think many of us share the vision that's similar to the operational issues associated with these products. Clinical trials are going to be prominent and around for a long time, and that these are very highly complex trials. They're high-risk trials, yet they share a lot of similarities. The resources needed, apheresis, the collecting of the cells, our cell therapy lab, where the stem cells are, where the products are harvested and manipulated and brought for infusion, lymphodepleting chemo. All these things are common themes in these different products. The budgeting considerations, the regulatory maintenance, the adverse event monitoring, the reporting requirements are all intense and a bit different for these things. And so I think it's very important that I think that the opportunity for a centrally supported resource seems very appropriate. And we are looking into that now. The School of Medicine is in the process of standing up a data safety monitoring committee and resource review committee for cell therapies in general to try and keep an eye on this, just again, because it's big and expansive. And so that's, I think, a vision that we will also be working toward as we work on our operational issues. So to finish things off, exciting times, lots to be done, broad, expanding, multi and cross-disciplinary. And I, for one, this is sort of my second act to work on this for the next 5, 6, 7 years, I hope. Super excited to work with everybody. It's been a great opportunity to get to know some new people and work with other divisions. And we only want that to continue to grow. Too many people to acknowledge, but in the various divisions, Gates Institute, Clinimmune, the Stem Cell Lab, apheresis, a couple of names highlighted here for folks who have been instrumental in helping to get this going. So thank you very much, and happy to take any questions.
John, thank you. That was truly a tour de force from clinical, operational, strategic, and then the exciting potential for the future. I'll open it up for questions from the group and the audience. And while we're waiting, maybe I'll start with one, John, as a sort of an inpatient provider. I want to talk a little bit about CRS, which keeps me awake at night and does a lot of sort of challenge in the hospital side of things. What do we know about patients who actually develop that? Are there particular patient risk factors or drug risk factors that you should be considering in terms of actually giving individuals CAR T and thinking about CRS proactively? Or is this one of those things where it's just hard to predict who's going to get into trouble?
Yeah, it's certainly a very active area of investigation. It's one we made a lot of progress on. I think one of the largest drivers of CRS risk is the burden of disease that a patient has when you put the cells into the patient. And we've gotten better and better at trying to have that burden be lower and lower, which is maybe the most important factor in reducing the severity of the CRS issues that we've been seeing. But also things about exactly how you create your CAR, whether it has a 4-1BB or a CD28 co-stimulatory molecule, seem to influence the way the T cells behave, how aggressively they behave, whether or not you're going to get a CRS. The amount of treatment a patient's had, the specific disease that they're dealing with, they're all factors that play into the risk. There have been a number of investigations of consideration of prophylactic approaches to avoiding it. At what level does one intervene? Of course, when we first started, everyone was terrified to give any sort of steroid or anything to a patient you put these T cells into because you think you might just kill off all the T cells. It's a funny story, a difference between an adult and children. At Penn, they also gave the first CAR T cells to CLL patients. And one of them was just some schmo adult who got discharged and went into the ER like 2 days later with CRS symptoms and like didn't tell anybody that he'd just gotten the first CAR T cells in the world. And they gave him a big whopping dose of steroids. And so we learned that that didn't necessarily mean the end of the world for the CAR T cells. But, and it does seem you can give low doses of steroids without negatively impacting efficacy. So we have guidelines. I mean, it's one of these problems. There's 5 different sets of guidelines, but I think people are coalescing around one set of guidelines around the grading and then the associated response. So we try to get this as algorithmic as we possibly can so that as many people as possible can, as comfortably as possible, deal with it. But yeah, it's a real thing, and it can be scary when it's bad, for sure.
Thank you. Dr. Messersmith.
Yeah, John, I was just curious, how do you think about education with cell therapies? And how do we train the next generation? Should a rheumatology fellow do a month on the cell therapy service, and hospitalists, should they be trained up as a sub-segment of the general population, hospitalists, et cetera? How do you think about that?
So you're digging right into a whole lot of real challenging questions. Well, so, I think we're all thinking about this, and I think we're all trying to figure out what the best model for this should be. I think some things that I think are true. Again, I can't highlight enough how fast this is all changing. So whatever we know today may not be true in a couple of years. So we can't be too wedded to anything. I do think there are some truths about these things that are going to continue to be true. I mean, mucking around with the immune system is going to cause immunologic issues. There is an accrediting body, Foundation for Accreditation for Cellular Therapy. We have our every 3-year evaluation on Friday, so good luck to us. But they establish a number of criteria that folks who are taking care of these patients in a regular way need to meet. And they include a bunch of education elements and experience elements and so forth. So folks who are going to be doing this in a significant way, I think we're going to have to come up with some system that you become basically certified to do it. But I do think, there are a lot of questions about the role of hospitalists, the role of APPs, the role of the different docs who are taking care of the patients for their primary disease that we need to work through. I think that the operating principles that we are working under is that we want to be inclusive. We want a system that works. We want to provide opportunities to those who are interested to be able to participate. And, I think that the conversations are ongoing. But I could easily envision in several years' time a dedicated cell therapy service that is staffed by a mixture of APPs, hospitalists, doctors in rheumatology, doctors in BMT, doctors in oncology who have expressed interest in this area. I think hopefully a grand rounds like this helps to stimulate some interest. I mean, this stuff is very cool. If you are a resident or fellow and you're not interested in this, I don't understand. But it's good stuff.
More questions, one over there. One of our chiefs. Speaking of residents being interested in this.
Right.
Thank you so much for your excellent talk. I was wondering, given the astronomical costs of these drugs, if you could speak a little bit to the insurance approval landscape, and then speak a little bit to how you think about equity and disparity mitigation in this field.
God, you guys are poking the tough questions here. Yeah, look, well, with respect to insurance and reimbursement, we negotiate our contracts with the different insurers. Again, I don't know how much weeds we want to get into any of this stuff, but when new products come out, the insurers will sort of, look at them, decide if they're going to approve them. And what we will typically do is do what we call single case agreements, where we do individual agreements with the insurers for individual patients at first. Then when we get more experience, we start doing contracts where we sort of are like, this is what we're going to get when we understand things a little better. Insurers have been approving these things. These cost-effective analyses are ongoing. There is definitely pressure, I think, to try and bring costs down. If the market gets too out of hand, the insurers are are gonna push back and then the hospitals are gonna get stuck in the middle and have to decide whether they'll do it at this rate or that rate. And that generates pressure to hopefully get the companies to bring the prices down. But it's an ever-going dance that we're working through and you know, is the way that it is. As to the issue of equity, look, this is a really challenging issue. This is an issue that we struggle with in cell therapies and perhaps even more significantly in stem cell transplant. And it's a little bit even more complicated than it might appear at first blush, I think, which I like to point out very importantly, because yes, there's the cost issue and like the money is a big deal for sure. You know, we have this law called HDC, Hospital Discounted Care, that was passed in Colorado. It's a whole discussion we could have also. But effectively, it says that if you come into a hospital, you have to be taken care of regardless of your ability to pay. Its applicability in the setting of stem cell transplant is complex because the law is not appropriately designed to deal with long-term care of patients, but it creates a lot of complexity. But there's the money issue, and that's an important issue. But the other issue that is really challenging for us is that these therapies, and maybe more transplant than CAR T, but CAR T very much too, they're very complicated and they require the patients to have social, economic, psychological support structures in place to get them through it. Because it really is not satisfying to kill somebody. And that's something that we do in stem cell transplant. And so we have to struggle not just with the financial issues, but whether we think that patients are reasonable to move forward on the basis of their other circumstances. And sometimes we have to make tough decisions on that front. And of course, that impacts the, you know, the more in an unfair way, certain patient populations. So, you know, it's tough. You know, it teaches you lessons quickly in reality. But our underlying principle is that we try to do the best for every person that we possibly can.
Dr. Gutman, we are at 1 o'clock. Thank you very much for an incredible grand rounds. Really appreciate it. Thank you.
Thank you all. Thank you.
Oh,
Oh, sorry.
It's okay.
Matt, when you Eric Campbell.